Hello, and welcome to Optimizing Your Quality of Life with Parkinson's. I'm Amanda Apolloni, Development Director for the Parkinson's Foundation Georgia chapter. Before we begin, I want to welcome those of you who are joining us for the first time and take a moment to share the mission of the Parkinson's Foundation. At the Parkinson's Foundation, we make life better for people living with Parkinson's by improving care and advancing research towards a cure. To achieve our mission, we pursue three goals: to improve care for everyone with Parkinson's, to advance research towards a cure, and to empower and educate our global community. And we do all this through building on the energy, experience, and passion of our global Parkinson's community. Here in Georgia, we support and collaborate with our two centers of excellence at Emory University and the Medical College of Georgia at Augusta University. We support local organizations through our community grants program and raise funding and awareness through our annual Walk for Parkinson's Moving Day Atlanta. We connect people with Parkinson's to safe and effective fitness programs through the PD Gladiator Fitness Network. We have two exciting programs coming up in collaboration with our Center of Excellence at the Medical College of Georgia at Augusta University. On August 20th in Augusta, join us for Restore, Recharge, and Reconnect, an event with the Kroc Center that will feature an inspirational speaker, entertainment, drawings, and lunch. For more information and to register, please contact Annie by phone or by email. On October 30th, we are hosting our first educational event in Macon, Georgia, that will focus on managing mid-stage Parkinson's disease. For more information and to register please visit parkinson.org/MaconEDU. We are thrilled to announce that Moving Day Atlanta, our annual Walk for Parkinson's, is returning to Piedmont Park on Saturday, October 16th. Register to join us and get your friends and family members involved in this inspirational community event. In addition to local programs, you can also participate in our PD Health at Home virtual program series. Learn more and register at parkinson.org/PDHealth. We encourage everyone with Parkinson's to enroll today in our PD Generation study, a national initiative that offers genetic testing and counseling at no cost to you. Participation can be either in person at one of our participating centers of excellence or from home through our telemedicine appointment and at-home cheek swab collection kit. Learn more and register at parkinson.org/PDGeneration. We would love to connect with you. Visit our chapter website and follow us on Facebook for local resources and support, or call our toll-free helpline for answers to your PD-related questions. Before we get started, I want to thank today's program sponsor, Amneal, for their unwavering support. We invite you to learn more about this sponsor by visiting our chapter supporters page. To kick things off today, we're going to check out this short video featuring my amazing parents, Karen and Wade Andrews, who will be talking about the ways to optimize your morning routine with Parkinson's. After the video, we are going to begin with our first live panel discussion. Please remember to submit your questions for today's panelists using the Q&A icon.
Oh gosh, you're up early this morning.
Yeah, Don's picked me up early. I haven't been in the park.
Oh gosh, Tai Chi in the park. How fun will that be?
Yeah.
Hey, I noticed you were moving a lot more fluid this morning.
Thank you for moving the furniture around for me.
I'm so glad that it helped. I never even realized that some of the rugs and the decor and where the furniture was, that was interfering with your freezing as you moved through the house. Hey, if you're going to go to Tai Chi early then, why don't you go ahead and take your medicine now? And I will go ahead and change the alarms on your phone so you get the reminders about an hour early then, right? Okay. Here, I'll do that up here when I'm in the kitchen. I'm going to get myself another cup of coffee. And I put some fruit out there, but I'll go ahead and get you the rest of the breakfast. I've learned from the dietitian what he had shared, that if we can lower the protein during your breakfast, that it's going to help with your medication being absorbed better into your system.
Did you happen to pick up sunscreen for me?
Oh my gosh, yes, I did. I'm so glad you reminded me.
I like the spray better because it's easier to apply.
Oh, terrific. Well, I'm so glad. And, you know, I didn't even realize until we spoke with your dermatologist that you were at such a higher risk for melanoma now that you have Parkinson's. So I'm glad that we learned that as well.
Thanks, Mom and Dad. Now we're going to bring our other panelists on camera for more tips and discussions around morning routines and how to get your day off to a great start. First things first, I'm going to have our panelists introduce themselves. Lloyd Spann, you're up first.
Hey, good morning. This is Lloyd Spann. I'm 68 years old. Was diagnosed 6 years ago at the age of 62, and I'm currently retired. I have been for the past few years volunteering with the Parkinson's Foundation here in the Atlanta and Georgia area.
Awesome. Thank you so much. Karen Andrews / Mom, you're up next.
Hey, I'm Karen Andrews. Unlike Lloyd, I'm not going to share my age, but my husband, your dad, Wade, he's had Parkinson's now for about 16 years, and I have an opportunity to volunteer with the Parkinson's Foundation for Moving Day and some of the advisory board stuff.
Awesome. Thank you so much. Dr. Brittany Hooker.
Hi, everybody. My name is Brittany Hooker. I am a physical therapist here in the Atlanta area. I work in the outpatient neuroclinical setting, and I treat patients with movement disorders. And I recognize several familiar names on the webinar today. So thank you all for joining us.
Awesome. Thank you so much. And then Dr. Lazarus.
Good morning, everyone. Amanda, thank you for inviting me to be part of this panel. My name is Joash Lazarus. I'm a movement disorder neurologist here in Atlanta, based at the Multiple Sclerosis Center in Atlanta, soon to be rebranded as the Atlanta Neuroscience Institute. And again, thank you for having me involved.
Absolutely. Thank you so much. Well, thank you guys for introducing yourself. Dr. Lazarus, I'm going to start with a couple questions for you. Everyone with Parkinson's disease seems to take different medications. What are some of your go-to medications and why?
That's a great question. You know, the most important point to remember is that no two patients' experience is exactly the same. Everyone has a different flavor, so to speak, of Parkinson's. And we try to define it, or at least we do define it by the movement aspect of it. And so most of the medications are really tailored or geared towards improving some form of movement, whether it's excess movement like tremor or too slow movements. And as we know, it's all really a manifestation of loss of dopamine in the brain. And so our gold standard, our go-to medication in 2021 is simply to replace the dopamine. And that comes in different forms. The most commonly available form is Sinemet. Also comes in extended release forms, a Sinemet IR or CR, and then a more commercialized form called Rytary, a combination of the two. But all these medications work at the same basic mechanism in the brain, and that's really to boost the amount of dopamine and hopefully to smoothen out the transmission of that signal that allows for smooth coordinated movements. At other times, we have adjunctive medications. So if the Sinemet itself does not accomplish our goal, or unfortunately causes a few side effects, then we add medications like dopamine agonists. A dopamine agonist can be a patch like Nupro or Mirapex or Requip, maybe more familiar names. But their role is essentially to smooth out the response of dopamine by kind of tricking the brain into thinking there's more dopamine present than really is present. And it has its own different category of side effect profiles. It works roughly 40 to 50% the strength of Levodopa itself. Therefore, it's not the gold standard, but it does have very good uses. And lastly, we use medications that keep the dopamine around longer in the brain. So good examples of that would be selegiline or risagiline, Azilect as it were, or a monoamine oxidase inhibitor, or Comtan, another medication that would allow the dopamine to last about 30 to 45 minutes longer in each dose. All of these are adjunctive, though. They all work by accentuating or making more efficient what dopamine is there. And so really the Sinemet's the gold standard.
Awesome. That's great information. Thank you. What makes people with Parkinson's so different, and how do the various medications work together to optimize daily living and manage symptoms that could interfere with the quality of life?
So another good question, the sets of challenges that Parkinson's patients face are so unique and so different. There's an overlap, of course, with other neurological disorders. So unfortunately, some Parkinson's patients have a lot of challenges with memory or concentration or thinking or bladder problems or sleeping problems. But what's really unique is the pattern of the movement problems that they have and the way in which they progress and the way in which they change over time, the temporal progression. So it really can be categorized as too much movement in some situations, which is the tremor or dyskinesia, or too little movement, a difficulty with fine motor skills or freezing of gait, which can be kind of the severe spectrum of that. And the way the medications work in general is to try to optimize those movements, to try to prevent the complications like dyskinesia. We're trying to improve the efficiency of the dopamine or the amount of dopamine to allow movement to occur unabated. So let's go through some of the common ones, for example, levodopa, which is Sinemet IR or CR or Rytary, is absorbed through the gut. It replaces the dopamine that's lost. If tremor is the predominant problem, we wholly expect or hope that the tremor would improve within 30 to 45 minutes and be maintained, be completely controlled for at least 3 to 4 hours, because these medications are at least 3 times a day dosing. The goal of medication, regardless of which category I refer to, is maintaining function. So it's quality of life and functional. Unfortunately, none of these medications are what we call disease modifying. They do not slow down the progression of the process in the brain. And that process in the brain is accumulation of a so-called toxic protein, which is the alpha-synuclein. But that doesn't matter, because if we can maintain function and quality of life, then it's kind of a functional therapeutic avenue anyway. And all of these medications, remember, are one facet of the management plan that's so much broader. And we're going to touch on things like exercise, for example, later on, and lifestyle changes. But that's how addressing a specific component of the movement problem like tremor is managed through a directed treatment option through the levodopa. So when levodopa works, and it works pretty well for most patients, unfortunately with time, sometimes the effect can wear off, and in a number of different ways. And the wearing off is quite common in patients who have the disease for more than 5 or 7 years. And that's when something like a dopamine agonist once a day can smooth out the response, so that when the levodopa dips, you're never running on empty, so to speak. There's still some medication that allows efficient movement. Or selegiline or rasagiline, Azilect, can also act by keeping the levodopa around a little longer to also smooth out that effect and prevent wearing off. And there's a few new classes of medicines. One is called Neurions. It's an adenosine receptor agonist. So it acts at a point in the brain that caffeine has also known to act at. And it's been shown to improve the amount of time patients are on. So when they have good function, minimal amount of Parkinson's symptoms, and if they do have any of those Parkinson's symptoms, it doesn't impact their function for that period of time. The other category of medicine is amantadine, or a newer form called Gocovri, which is once a day dosing. And it has two really big benefits for Parkinson's patients. One, again, is to add about 1.5 hours or 2 hours during the day of good functional time. But the second is to directly treat the dyskinesia, these new involuntary, uncontrollable, and sometimes disparageable movements that affect disability. And so it has a dual purpose there.
Awesome. Thank you so much. What is the best tip for taking medications in the morning and getting off on the right foot? Any breakfast or food recommendations?
Sure. As a generic answer, and unfortunately, a lot of my answers will be generic today because it depends on so much on the patient experience. But as a generic answer, high protein content, as was mentioned in the video, can impact the absorption of the levodopa. And so we try to separate that as much as we can. Now, at the beginning, especially for early onset Parkinson's, when symptoms are relatively milder, I think we can get away with dosing it with meals because it's easier to manage. And the effect of the protein may not be noticeable early on. But sometimes as things change, I try to separate it out a bit so that the medication is 30 minutes before a meal or an hour after the meal. Some patients don't tolerate that because of nausea, so you try to take it at least for the snack. And that's often a good point surrounding the meals. But in terms of the early morning symptoms, there's a couple of things to be aware of, especially early on in Parkinson's. Sleeping can be very restorative. So patients will have a lot of symptoms the day before, but their best time of the day can be the first hour or two upon waking, even before the medicines kick in, because sleep has a very good restorative effect. Conversely, other patients who have tremor may be woken in the morning because their nighttime dose of medications are wearing off. And to address that, it may not need a change of the morning medicine. The better approach may be a long-acting medication at night before bedtime, or something in the middle of the night that can continue through the morning and allow the morning to be smoother and just better experience. And lastly, and unfortunately, the more extreme version of that is something we call morning echinacea. So this experience where getting out of bed or even turning in bed is very difficult because of the rigidity and the stiffness. And freezing is very prominent. And in those patients, you want something that's going to act pretty fast. A tablet like the Cinemet IR, which will take 30 to 45 or even an hour to kick in, may not be appropriate then. And so we use alternative agents. So the dopamine agonist I mentioned earlier, but administered through injection under the skin or through a patch or through an inhaler, or now a newer version called Kimobi under the tongue where it's absorbed very fast. So those are on-demand or PRN Parkinson's medications, and they can act very quickly to bridge the gap between levodopa dose or in the morning in those situations.
Awesome. Well, thank you so much for that. Lloyd, how do you get your day off on the right foot? No pun intended.
Thanks, Amanda. Well, I'm usually really stiff when I first wake up in the morning. So actually I do a little bit of stretching before I get out of bed, just stretching my arms and my legs just a little bit. Then because my legs are stiff when I first get up, I usually stand up and stretch a little bit and then begin walking rather slowly with small steps and then kind of continue to expand my length of stride as I go until I get a little bit more normal and my legs begin to loosen up on me. I also do some further stretching as part of my workout routine. My objective is to work out usually 5 to 6 days a week. I don't always do that. I wish I could say I did that regularly, and I notice a difference when I don't do that. I can really tell I don't feel as strong and as healthy when I don't do that. I do like to do it mid-morning, so I give time for me to be able to take my medication in the morning, have breakfast, and kind of at the optimum time during my 4-hour window between 8 and noon is when I try to do my exercising. I find it really works well for me. I feel the best at that time. And then secondly, I find that if I don't do it and schedule it in the morning and I let it wait till the afternoon, next thing I know, I've let something else take over and I've actually not done any exercising at all. So I've really found it critical to schedule it on a daily basis and not let it just be whenever I can get to it. Because when I get to it, it usually doesn't work very well. Relative to my meds, I do it 60 minutes before I take my meds in the early morning, 60 minutes before I take breakfast. I find that it helps, and like Dr. Lazarus had mentioned, not taking it with protein it has been shown to be beneficial. So I try to avoid protein, and then the guideline that I've heard is that maybe optimum is an hour before, and then as much as 2 hours after taking the medication. Again, that can be challenging relative to what you're eating and everything, but that tends to work for me fairly well, but it can be kind of tricky trying to schedule that. So I try to take my medication on the same schedule every day because one, it's easier to keep up with. And then secondly, the body kind of expects it once you get a routine established. So I start out at usually at 7:30 to 8 o'clock at the latest, and then usually go in 4-hour increments after that. When I do that, I take it with 6 to 8 ounces of water, try to get a lot of hydration first thing in the morning. And I've learned that actually it's important to drink water, not just anything to drink, but drinking water throughout the day for hydration, because it's important for both general health as well as brain health. So that's some of the things that I do relative to my situation, Amanda.
Those are great tips, Lloyd. Thank you so much. All right, Mom, a few questions for you. How do you help your husband get going in the morning?
In our case, Wade or Dad, he's always been an early riser. So, and even more so with Parkinson's, since he's had continued sleep problems. I really think of my morning contributions are more about reminders for the day, well, except making coffee, right? So let me back up for a minute. So absolutely, I make sure that the coffee pot is ready to go in the morning. We're not yet Keurig adopters. So just getting that ready. So when he does get up, he just has to hit that start button. But I think of myself as, being more making sure that there's always something to do and look forward to doing, throughout the day. As I mentioned, he's progressed in the disease, right? It's been about 16 years now. And there's a myriad of things that he can just no longer do. But for every activity, sport, or hobby that he can't do, we've worked together to replace it with something that he can do. And I think just, working to be somewhat of a positive influence as a care partner, can be really important. We tend to follow, we've kind of named it within the house as the coffee cup guideline that actually started with you when you think about you and your husband. So I know you had this crazy collection of coffee cups, right? So as soon as you wanted to add a new one, your husband would say, nope, sorry, if you're going to get a new one, you got to throw one out. So we kind of do that in reverse in our house, through his progression, as we look at activities that have, come off the list and he can no longer do them. It's my job, it's our job together to make sure we bring in something new, that he can do. We tease too. Maybe that means we gave up going to the gun range to playing cornhole, right? So you just have to find ways to adapt. And I think just being a motivator when you can, is super important.
Awesome. Thanks for those tips and for exposing my coffee mug habit. Do you help with eating, dressing, stretching, etc.? Are there small things that you do that seem to make a difference?
Yeah, not, I wouldn't necessarily say as much as helping with dressing. There, in some cases, Wade definitely has on and off periods, and the off periods are longer, than the on periods now in some instances. So from dressing, I remember when we both first rediscovered the shoehorn, we looked at each other like, oh my gosh, why didn't we think of this sooner? So I certainly recommend all Parkinson's patients, make sure there's a couple shoehorns around the house. But I think around dressing, it's some of the favorite shirts that had buttons, they're just not the favorite shirts anymore, right? So we look at different ways where, he can remain dependent while he's dressing as well. Also, I mentioned it once before earlier about, just finding different things to do. So when you think about small things that make a difference, it's just being aware, acting as a concierge, if you will, as you can throughout the day. So walking is very helpful to Wade. And, as unlike Lloyd, I heard you share, sometimes you can do some longer walks. And so we have had to adjust. So Wade will do shorter walks, but we try to do them frequently throughout the day. And even if it just means if I notice he's getting really rigid, we'll get up and we'll just walk around the block, just a short walk.
Awesome. Well, thank you for going over those. I appreciate that. All right, Brittany, last but not least, as a physical therapist, what are some of the best morning stretches that people should try and do before rolling out of bed?
Yeah, I think it's really important that people with Parkinson's emphasize stretching, in particular stretches that open up the body and stretch muscles that typically flex and rotate our different joints. Those are typically the muscles that are affected by Parkinson's and get stiff and can contribute to some stooped posture and shuffling gait. I would recommend while you're laying down in bed, doing some stretches, maybe with your arms out to the side, stretching your chest and reaching up over your head. You can pull your knees up to your chest one at a time or both. Opening and closing your hands really big and wiggling your toes and your fingers. Once you're in sitting, even reaching down to the floor and reaching up to the ceiling. Reaching out to the sides, just really stretching out your trunk really well. And in sitting or standing, even doing some marching might be help to kind of prime your body for movement once you get up and going.
Awesome, that's very helpful. For someone with Parkinson's, is it ideal to stretch in the morning and then exercise once the medications have kicked in?
Yeah, and I think it depends, kind of as Lloyd mentioned, he has his own personal schedule that works best for him. So I think it depends on the person's preference. Most people do prefer to stretch earlier in the morning because they feel stiffer and slower when they first get up in the morning. Their medicine may not have kicked in yet, so it's an easier type of exercise to do. So I do think stretching first thing in the morning is helpful. And then I would recommend trying to exercise, especially more vigorous or high intensity exercise during your peak medication dose times, which may be mid-morning, like Lloyd mentioned, or it may be a different time of day, depending on your medication schedule, but you'll be able to work harder and get more out of the exercises when you feel and can move your best. Some people feel more fatigued later in the day, so they prefer to exercise in the mornings. Some people, it takes them a while for their medication to get kicked in the earlier parts of the day, so they prefer to exercise later on in the afternoon. So I would definitely recommend trying to coordinate your exercise schedule and any fitness classes and or your physical therapy appointments during the time of day that you feel best. But with that being said, those off times when you're feeling slower and stiffer and have more difficulty moving are inevitable. So as a physical therapist, I can help work on, freezing and walking and getting in and out of bed during those off times so that you can still move and do things independently during those times.
Awesome. Thank you so much. That's very helpful.
Hey, I wanted to show you that John just finished installing these grips for you. So I was getting really nervous. I was watching you come up off the stairs, and when you would get to the top, you were losing your balance a little bit, and I was fearful you were going to fall back down the stairs. So let me show you how these work. When you're coming up the stairs, you'll have the handrail here, but then with your other hand, you just want to make sure that you grab this grip as you come up, and that's going to keep you from having to feel like perhaps you're falling back down the stairs.
I really needed those.
Great, I'm so glad. Oh, the other thing I wanted to tell you was I went ahead and I got your speech therapy classes scheduled. So your speech therapy classes they'll start today and then every Tuesday at 1:30, and I put them all on the schedule here for you so you can see them in the calendar.
Will you be able to drive me midday?
Yeah, no, I won't. But what I found was in the Lyft app, I can go ahead and I can pre-schedule all of the rides. So Lyft will pick you up and then they'll bring you back home at the time that I scheduled.
Great. What about the paperwork? I don't be able to read my handwriting.
Yeah, right. I know. That's so true. I know that handwriting is such a challenge. But I called ahead and they were able to send me all the forms, and I filled them all out, so everything is all set. You don't have to worry about any of that right now.
Oh, I meant to tell you, I finished my breathing exercises.
Oh, good, because I was just going to ask you, now that you're good with the schedule, I noticed the time, and we've got to go ahead and get our walk in. Do you have your tracker all set?
It's on.
Great, I think you're going to beat 7,000 steps today. And when we go, I found a new path that we can walk on through that new All Trails app. It helps me find ones that are just moderate and they have fully paved pathways. Let's go.
That's great.
Now we're going to bring our other panelists on camera for more tips and discussions around successfully navigating daily activities. Dr. Lazarus, again, I will start with you. How important is it to see a Parkinson's expert or movement disorder specialist?
Well, Amanda, I want to start by saying that even general neurologists are absolutely invaluable in taking care of Parkinson's patients, but there's some differences. And for example, a movement disorder neurologist like myself, just from a training standpoint, we have a little more focus in movement disorder area, including Parkinson's. So we spent 2 years extra focusing on Parkinson's disease treatment, diagnosis, and even surgical management. And so where we differ is that we tend to spend or dedicate more of our time solely on patients like Parkinson's and essential tremor. And for that reason, may be more in touch with the latest clinical trials and have a little more experience with managing the very complicated medication regimens that we talked about earlier on. Certainly with things like DBS surgery or focused ultrasound surgery, those are very highly specialized forms of treatment that really should be left to people who focus on that basically day in and day out, because they change so much. The benefit can be so great, but there are risks involved as well. And so the decision-making behind them can be very complex. Having said that, We don't treat diseases, we treat patients. And general neurologists are experts on patients. They're experts on the people they treat, more so even than the specialists like myself, who tend to become more kind of disease-oriented or disease-centric. And so general neurologists and movement disorder neurologists tend to form a team around movement disorder physical therapists, neuropsychologists. We all form part of a multidisciplinary team. And patients who, for instance, get the majority of their care from a general neurologist may benefit, therefore, from expanding their scope to involve a movement disorder neurologist and a physical therapy team and a psychology team, rather than replacing one. It's all very team directed, and that's really where the role of a movement disorder specialist would be in helping guide that team.
Awesome. What if you don't live near a Parkinson's disease expert? Should you travel at least once a year or utilize telemedicine?
I think both are very good options. They're both analogous to each other, and things are going to change or have changed over the last year, forcefully so due to COVID. But in Georgia, the state of movement disorder care, at least in my view, is such that we have several disease centers of excellence. So the Center for Augusta is one, Emory is another. I'm a movement disorder specialist in Atlanta. There's a third movement disorder specialist at Grady as well. And we all tend to navigate or network the area with general neurologists throughout the community, including rural Georgia. And so they have good access to us to telehealth, for example. In the interim, I think the best care would be to at least have one in-person neurological exam annually. You know, that's a very good standard to have because things can change and you can have a more comprehensive view of how to make medication changes, whether or not things have changed to the point that a surgical decision needs to be made, whether cognition has changed to the point more than just lifestyle and exercise needs to be tweaked, but we need to redirect the direction in which we're going. And so that time point is really good to say that you shouldn't go more than a year without a physical examination. Where telemedicine comes in, we know it's very effective in making medication changes. It could be down the line effective in having data points to help us triage patients for surgery or not, but exclusive telemedicine I would not recommend unless that's complemented by even a general neurology follow-up. And so again, I understand the challenges for rural Georgia. We're working right now to try to expand both telehealth as well as in-person rural clinics. But the other avenue that's going to expand access to care is development of alternate physicians such as Dr. Hooker and her colleagues, for example, that give us a time point, an entry point into the healthcare system and communicate with us if things were to change. And neuropsychologists in the city have done the same as well. So this is a complicated multidisciplinary team because it's a complicated multidisciplinary disorder, and that's probably the best way to manage it.
Awesome. That's very helpful. Thank you. How do you recommend that people with Parkinson's keep up their energy levels during the day?
That's a good question. And again, it's a balanced question. It really depends on the type of issues people are having. In broad categories, the way to manage this is number one, lifestyle changes. That includes exercise, sleep hygiene, and nutrition. And number two, medication changes. So in terms of the lifestyle changes, exercise is proven benefit with regards to energy down the line. The long-term benefit often supersedes the short-term subjective report. In other words, it's difficult to get going. It's difficult to start an exercise regimen, even for people without Parkinson's. And the immediate impact may be the opposite, a lot of fatigue and wearing down, but exercise tolerance builds over time. And after a month or 6 weeks, patients report improved energy, improved sleep that dovetails into even more energy and better resilience. And the pleiotropic benefits of exercise are just diverse, meaning it impacts cognition, it impacts mental fatigue, it impacts the mood and drive that you have from depression and the fatigue that can accompany it, as well as the physical fatigue. And so that's always the foundation on which I try to address the issue. And then there's nutrition changes as well. Focusing on a low sugar diet and a high fiber diet can help in so many ways from a health perspective. It also helps, as we've alluded to several times, the absorption of medication, which has its own benefit later on. And one of the key issues in addressing fatigue is sleep dysfunction in Parkinson's, because it can be very subtle, it can be unrecognized, but it can be hugely significant. Things like insomnia, and there's a few other specifically sleep disorders that we can talk about later, that can fragment sleep. They have good specific treatment options for them. And if they're well treated, fatigue can improve significantly. And lastly, and this is why it's so important to have more than just a movement disorder neurologist on board, but a good primary care physician and a good general neurologist that has a good relationship with you. Subtle depression can be devastating when it comes not just to cognitive and motor function, but fatigue is the first symptom. And often it can be difficult if you're following with a movement disorder specialist once a year or once every 6 months to really pick up on the subtle clues of this person is in a different place emotionally and mentally than they were 6 months ago. But if you have a very strong connection and a really good relationship with someone, a primary care physician or a general neurologist or community neurologist, it's much easier to pick up on that. So those are kind of relationship and lifestyle changes that are important. From a medication standpoint, we want to be aware that lots of the medications have a side effect of fatigue. Sinemet is one, Nupro and Mirapex are the other two. So we try to adjust the dosing to nighttime dosing or drop the doses and increase how often you take them so it doesn't cause sedation. And several of them have the opposite effect. So selegiline is known to break down almost into a stimulant, and that can boost your energy. And we often add that on. Or there's medications that are stimulants, for lack of a better word. So you may recognize the name Provigil or Nuvigil, which can be added on to help. But adding on medication is the second choice. Adjusting the medications that are there or adjusting the lifestyle really should be the foundation and should be the primary goal.
Awesome. And then should people take naps or should they avoid them?
There's no harm in taking naps at all. Again, it depends on lifestyle and the comorbidities and the patient situation itself. What does concern us if they're unintentional? So if patients are falling asleep in the afternoon, or even worse, if they're falling asleep while driving a traffic light in a conversation, and we can call those sleep attacks. We know that several medication categories, like the dopamine agonists, are linked to those, and there's a warning sign for us to adjust something, or untreated sleep apnea is linked to that. And so those are all kind of disconcerting signs for us. But if they're a routine, scheduled lifestyle change or regimen change, and that can really have some benefit, because we mentioned the restorative effect of sleep earlier on. Patients kind of feel recharged from a motor standpoint when they awake. Sometimes the symptoms are much better, and they get an hour or two of really good function after that.
Wonderful. Thank you for that.
Right.
Lloyd, what are some tips you have for getting through the day in terms of medication, exercise, and keeping your energy up?
Oh, thanks, Amanda. One of the things we talked about already really is about scheduling the medication. So I find it's important to schedule eating around the medication schedule, to establish a good medication schedule and stay on it kind of no matter what, and then do the best I possibly can, work my food intake around that. I think it's critical to make sure that you stay on that and not postpone a dose, because your brain and your system is expecting to have those come in at the intervals that you've set up. Particularly in the afternoon, when I try to do my exercising in the morning, but in the afternoon I'm often doing some work around the house or out in the yard or something like that, and that's when I kind of get fatigued. And I found that what I often will do is add maybe a half a tablet of Sinemet somewhere in the middle of the afternoon to kind of give me a bit of a boost, if you will, to kind of get me through the rest of the afternoon. And if I get too tired, I found rather than dragging myself around, is just to come in and relax for a little bit, and then I usually get my energy back, and then I can go and finish up what I'm doing. Or I might just decide that since I'm retired, that's enough for today, and I'll just go take a shower and call it a day. So I was going to mention, the other thing was relative to, I guess, eating is, I've learned a lot about nutrition, like Dr. Lazarus has talked about, and I follow an anti-inflammatory diet. The Mediterranean diet is a great way to get started with that. A real nemesis for me is sugar and refined carbs. I keep working on that every day, and I still got to work, because I learned how unhealthy that is for the brain. So the nutrition, the food that we eat and supplements we take is really an important part of my plan. And one of the challenges that I've found, and I think it's important for people to do, is to find a nutritionist to help you with this, but one that knows a little bit about brain health, because it is a little bit different. It's not necessarily just basic nutrition, it's really nutrition relative to brain health. So there is somebody here locally in the Atlanta area, and I know there are others, but find somebody who is a good nutritionist and is familiar with brain health.
Awesome. Thanks, Lloyd. All right, Mom, a few questions for you. Do you attend doctor and therapy appointments with Dad? If so, what are some tips to ensure meaningful conversations with providers, whether you can or cannot attend?
I do attend appointments when I'm able, and I always try to attend when there's a first appointment, first time we're seeing a medical provider or first time we're seeing a therapist. Sometimes because my work schedule, it's just not always feasible. We've really come to accept that this is okay. And at times we reach out to family members and friends for assistance with appointments and various medical events. And certainly I encourage the partner care community to do that as well. When it's a lesser appointment or one where, Wade or Dad is going to go solo, I do make sure, we saw this noted in the video, and I do make sure that the paperwork is taken care of prior to his visit. Sometimes, dependent on executive functioning or where he is in an on or off time with the paperwork as well, it can be really challenging to fill out all of that paperwork. So I would certainly encourage the care partners to make sure, even if it's something, just making sure that the medical insurance is covered and there's no questions when the patient is going to go and check in first. So there's no confusion at the time of the appointment as it pertains to payment or what insurance is or is not going to cover. And also I just wanted to pick up on something Dr. Lazarus said in regards to, I heard the doctor mention around PCP or the primary care physician. We've also found that the primary care physician can be really a critical part of the medical network. Again, I would just encourage the community to try to partner with a PCP who really recognizes, I'm going to say, the totality that PD has on a patient's overall health, because we found that it can be really critical in correctly diagnosing a particular ailment, and it otherwise could be easily misdiagnosed if there's not a full understanding of what PD, can do for symptoms, non-motor symptoms as well as motor symptoms.
Awesome, that's very helpful. Thank you. As someone who is still working, how do you manage your work schedule and support your husband throughout the day? Any tips for other working care partners?
One thing I mentioned a second ago is that it's okay to ask for help. And again, I think I'm speaking more to the care partner community now. And when I say that is, really recognize that it is okay to reach out and ask for assistance. Sometimes it can become overwhelming. But, one thing that we do, and if I cannot be there, throughout the entire day, when we look at the different events or activities that are planned, a central calendar is really critical, what we've found anyway. And we saw that in the video a little bit. We're actually moving in our house, moving away from the paper-based or the book type calendar that you saw. And we're going to put it on the wall. We're going to create a big wall calendar where, Wade can just look easily at the calendar if I'm not at home or if I'm not in the room with him, and understand, what is this next event that really needs to happen, in the next hour or so. The other things, if I'm not home, some of the things that we found effective is food prep. So, I've found, again, by being attentive, I should say, as a care partner. And I learned, there were just some snacks that Wade just wouldn't eat because maybe it was too difficult to get them chopped up or cut up or prepped, being ready to eat. So try to do those things the night before, the day of, and try to do some of that food prep so that those healthy foods, we've talked about less sugar and when you need to avoid protein, making sure some of those food items are readily accessible to the patient, in the house throughout the day. And then the last thing I just want to mention real quick, again, just kind of picking up on something that was on the video. If you're not there with your Parkinson's patient every day, all day, scheduling those rides when, you can't find a friend or family member to help you to get to an appointment. Some of these ride apps are great. You can go in and you can schedule the pickup. You can schedule, when they're going to be dropped off and they're going to be picked up again. You can do the prepayment in the app. And that does, wonderful things to really encourage continued independence and frees up you as a care partner's schedule when you can't be there at all times to take him or her to the appointment.
Awesome. And then I know you touched on some of this during the video, but what are some ways that you help keep your home safe? Examples, clearing pathways across the home, keeping things organized. Do you guys use any assistive devices during the day or during meal times?
And In this video, we did reference that new stair grip, and sometimes it's really important. It's about being super aware and watching for things that you might not have thought to normally pause to watch. In our case, we noticed that Wade was having increasing challenges with his balance. And as I watched him on the stairs, we do have some stairs in our home right now that just can't be avoided. So as I watched those, I could see that, it was certainly throwing off his timing. And there was that, leaning backwards as he came up to the top of the stairs. So we installed those grips at the top of the stairs. That's been helpful. I would encourage other members of the community to think about that. If you do have steps in your home, just be super mindful and aware of what's happening on those steps. And just because you reach the top step doesn't necessarily mean that all is good and you can breathe easy. You got to make sure that you're effectively moving away from the landing, away from where those steps are. The other thing too, if you think about a device or how to help with different assisted devices throughout the day, something as simple as a larger sized tablespoon versus the standard teaspoon. There are some devices that help with tremors. I know prior to Wade's deep brain stimulation surgery, the tremor was, one of his pronounced symptoms. And we did invest in and tried one of those eating utensils that helped to counteract against the tremors. But even now, we used to tease, you got to keep your sense of humor, right? We used to tease before if we'd go out to eat. And if I sat on the right side of him, I never had to order a salad because I could always end up with half of his salad on my plate. And that's what we would laugh about. But now we've learned, hey, move to chopped salads. It is super easy to eat a chopped salad with a large tablespoon. So again, I just kind of bring up those things because I really think it's more about truly being aware.
Awesome. Thank you so much. Brittany, how important is it to have a regular workout routine?
Good question, Amanda. So it is so important, and it's important not just for people with Parkinson's, but for everybody. I think as humans, we're so good at just finding any possible excuse to talk ourselves out of doing things that we don't want to do. But getting in a regular routine is even more important for someone with Parkinson's disease because exercise is a form of medicine for them. So it's really important that you don't skip that part of your routine. As Dr. Lazarus touched on, exercise improves mobility and cognition and quality of life. It can help improve sleep and your Parkinson's symptoms and even can slow the disease progression. So it's super important to establish a routine to ensure you don't skip exercise. Some recommendations I usually offer to find an accountability buddy or sign up for an exercise class that you're less likely to skip than if you're doing it on your own. As we saw in the video, Wade set a step goal for 7,000 steps a day. So that's another way to make sure that you're getting enough exercise. And there's some pretty affordable activity trackers now too that would allow you to do that. You can even compete with a family member or find a friend that you want to compete and see who can get the most steps in a week. If you're a checklist person, you can make a checklist of all of your exercises or your weekly exercise goals and put it somewhere that you'll see it frequently and check it off as you do it. And I usually tell my patients to find a time of day that is best for you, whatever time that is, as we talked about during the last section. And pick a time and set an appointment with yourself because my patients make appointments with me and they come exercise for a full hour and they very rarely will cancel an appointment with me. So I try to encourage them to set appointments with themselves and not cancel on themselves, just like they wouldn't with me.
Awesome. That's a really good tip. What types of exercise are best for someone with Parkinson's, and how often do people with Parkinson's need to exercise?
Yeah, good question. And this is a really common question, and it's a really difficult question to answer. So I'll just give the very general answer. People with Parkinson's are recommended to do aerobic exercise about 150 minutes a week. So if you break that down into 30-minute intervals, that would be about 5 days a week. I recommend everyone do some sort of exercise most days of the week, but aerobic is very important, maybe starting at a moderate intensity, like 4 to 5 out of 10 on a scale of 0 to 10 of how difficult it is, and then progressing to more vigorous or higher intensity aerobic exercise around a 7 or 8 on that scale. And I think shooting for a goal of 5 days a week with aerobic exercise is good. And then it's also recommended that everyone does like a flexibility, stretching program, strength training, balance, agility, and multitasking, each of those types of activities 2 to 3 days a week. So it's a lot to digest and kind of organize, and it can be overwhelming. So I would recommend seek out a physical therapist in your area that can assess your specific impairments and help you prioritize where to begin with the program and what areas you may want to focus on specifically.
Awesome. You kind of just answered my last question, but for someone who isn't exercising, should they see a physical therapist before beginning? And I'm assuming that answer is yes.
Yes. And so, as I just mentioned, the weekly exercise recommendations for people with Parkinson's can be a lot, especially for someone who isn't used to exercise and this is kind of new to them. So a trained physical therapist can help get you started, make it less overwhelming and less confusing. We can help you identify your specific exercise needs and help you prioritize what you need to focus on. For example, someone whose primary Parkinson's impairment is more of like stiffness and rigidity, they may need to be doing stretching every day, despite the guideline recommending 2 to 3 times a week, versus someone whose main issue is freezing of gait or imbalance would need to be doing some sort of balance or walking exercise every day, which is more than what the guideline is. So it's really dependent on each individual person and their specific Parkinson's disease. But another thing to touch on is community exercise classes are also a great place to start too. And we are lucky enough here in Atlanta that we have a great fitness network that's comprised of a variety of group and one-on-one exercise options, taught by fitness instructors with extra training in Parkinson's. So you guys can access that list of group exercise classes and our fitness network on the Parkinson's Foundation website.
Awesome. Thanks, Brittany. That's wonderful information to have. So now, before we move on to our next section, we are going to hear from one of our local chapter board members, Paul Tucker, on tips for navigating Parkinson's in the workplace.
Hi, my name is Paul Tucker, and I am a person living with Parkinson's disease. I was diagnosed in 2017, but for the most part, I've kept most of my symptoms and my diagnosis to myself. I have not mentioned it to a lot of people at work. I currently serve as the CEO of a local dental organization, so I have a little bit of ability to hide things, I guess I'd say, better than others. But regardless, I wanted to try to give a few tips that might help those of you who are listening to this video with regards to managing your Parkinson's disease at the workplace. I guess the first thing that I would say is, from my perspective, the most important thing that I try to maintain is an adequate sleep cycle. So I think we all know that if we are losing sleep, that it can sometimes cause some level of anxiety, perhaps. But I know myself, when I lose sleep, that my tremors sometimes break through more easily than not. So the first thing I would recommend is that you get a really good night's sleep. Try to stay to a specific sleeping pattern if you can, a specific time that you go to bed, a specific time that you get up, and be consistent in that. And hopefully that will help somewhat. Secondarily to that, I would say, is the timing of your meds. I get up at about 6 a.m. in the morning. The first thing I do at about 6:15 after I brush my teeth is take my meds, my carbidopa, levodopa. And that usually kicks in, and my tremors are under control by the time I get into the office, which is at about 7:30, 7:45. I take a second dose at about 1 p.m., which holds me for the rest of the day. So I would say that once you get your medication timeline down, stick to it. Try not to forget. Set some alarms if you need to on your cell phones to remind you to actually take your medication. Another tip, I present a lot. I've got a whole company of individuals that reports up through me. So I have a lot of conversations that I need to have with them individually and as a group. So one thing that I would suggest is don't put your hand in your pocket if you're actually trying to stop your tremors from being visible. If you put your hand in your pocket, the only thing you're doing is making your pocket shake, and then your whole pant leg shakes, and then everybody knows what's going on. So I would recommend that you not do that. So my suggestion is that you get a pen. I don't have one here handy with me right now, but I'll just demonstrate on another pen. They actually have pens that are specific for Parkinson's disease patients with a little bit thicker of an area towards the actual tip of the pen. It helps to grasp a little bit better, and it's easier to write. So that's a good thing if you have to actually sign your name a lot of things. But I would also suggest just keeping a pen in your hand, and because if you keep a pen in your hand like I'm doing right now, chances are you're not going to see a tremor because it's a resting tremor and your hand's not resting. So keep this in your hand. Another thing that you could do, something that I do as well if I have a meeting in my office, one-on-one with maybe one or two individuals, is I have a hand exerciser. And I basically just squeeze this periodically during a discussion. And, people just think that I'm trying to strengthen the muscles in my hand. Nobody takes notice of any tremor or anything of that nature. And I guess lastly, the thing that I would suggest is that even though you're at work, still try to get some level of exercise. I try to get out at lunch. At home, I do a lot of cycling, but I can't do that here at the office, obviously. I try to get out and at least do a walk, do some stretching in my office. I shut the door, I lay on the floor, and I do some stretching exercises. So, that seems to help alleviate a little bit of the stiffness that I have in my right leg. And I'm able to walk. My gait is actually pretty good, to be quite honest with you. So I hope some of these things are helpful for you. As I've said, get a good night's sleep, time your meds correctly, keep something in your hand to make sure your tremors don't break through. Don't put your hand in your pocket. I find that to be more adversarial than not. So keep the pen in your hand, get a hand exerciser, and don't hesitate if you have the opportunity to do some exercises at lunch. So those are, a couple of tips that I try to implement on a day-to-day basis, and hopefully one or two of those will help you as well. Thanks. Bye.
Those are great tips to have. For more information on navigating the workplace, you can also contact our toll-free Parkinson's Foundation helpline at 1-800-4PD-INFO. That's 1-800-473-4636. Now we are going to move on to our final session and get more tips from Karen and Wade on staying socially connected and getting a good night's sleep.
So I really liked this place. I liked the restaurant. I hope that you did as well. I thought the food was great, and I liked that they would take a reservation, because when I called, I asked them to seat us closest to the door.
That's good. Help me get in and out.
Oh, good. And the wine list was good. I'm glad we just kept it to one glass. I know that sometimes the wine can interfere with your medicine, so if we want a second glass, we can always just wait until we get home.
Well, is Harm and Donna coming over tomorrow night?
They are, yes. It's just going to be the four of us, though, because what I noticed was that sometimes if you get into a larger group, it can be more difficult for you to join in on the conversation. So we'll still see everybody else, but we'll start to do it in smaller groups.
Good. That's a good idea. And by the way, will you stop at the drugstore for me? I'm low melatonin.
Oh gosh, okay, I'm glad you told me that. That really seems to be making a difference. You seem to be getting a much more restful sleep.
I am.
Good.
I gotta notice from my Marine camera that they start they start that. They left the package for me.
Oh, you know what that is? I ordered us another set of those satin sheets. It seems to really help. You seem to be sliding in and out of bed a little bit easier.
They make a real difference.
Super. All right, well, buckle up. We'll head home.
Sorry. We are now going to move on. Dr. Lazarus, can you please briefly discuss some of the more common sleep disorders in Parkinson's?
Absolutely. So there are a few common sleep disorders and then more unique to Parkinson's. I'll start off with the common ones that are prevalent, not just in PD, but in the normal population as well. One common thread amongst them is that anything that disrupts sleep or disrupts quality of sleep is going to disrupt the Parkinson's symptoms, be they motor or non-motor. And so they're all very important to address at an early stage. But by far the commonest got to be insomnia. And it may not be just difficulty falling asleep, but fragmented sleep, so frequent waking during the night, or waking too early and not being able to fall asleep again. Another common coexisting disorders that we want to exclude that's very treatable is sleep apnea. And the typical symptoms there, apart from frequent waking or disturbed breathing during the night, is early morning headache or dry mouth. Both of those can be signifying high pressure that's due to the sleep apnea, and it's easily addressable. And then there's lastly, drooling, which is often kind of more seen as a nuisance or not really a disabling symptom during the day, can be accompanied by nocturnal sialorrhea as well. The nocturnal sialorrhea can result in disordered breathing. And so we have very good treatment options for all three of those. But the net effect of insomnia and sleep apnea and sleep disordered breathing is that you're not getting consistent sleep for 6 or 8 hours, and you're not getting good quality of sleep because they're micro awakenings. You awake during the night without realizing it, and that really disrupts the rhythm of sleep. And so the good restorative effect of sleep is altered as well, and that reflects in poor Parkinson control. And then there's more specific or unique symptoms that tend to go along with Parkinson's disease. Restless legs is one. We know it's very common in the general population, but if you look at the incidence or how common it is in those without Parkinson's and those with Parkinson's, it's probably more common in the patients with Parkinson's. And it's good to be aware of that because some of the treatment options overlap. We use the dopamine agonists, for example, commonly for both disorders, and Sinemet for both disorders, but the way in which we prescribe them in relation to the dose or the timing may differ. And so it's very good to be aware of these potential symptoms and discuss them with your doctor, because the way in which we treat them can differ quite significantly. And then the last disorder is a parasomnia. We call it REM behavior disorder. And the simplest way of describing that, it almost seems like someone is acting out their dreams at night. So talking, but not just inappropriately, but almost having a full conversation, or really cohesive motor activity, like they're riding a bike or trying to jump off the bed, like jumping off a cliff. And the obvious implication is the risk of hurting yourself or hurting a partner, hurting someone else. But once again, they're reflective of just poor sleep function, and they just tend to worsen symptoms throughout. They all have very specific treatment options for them, so it's important to be aware of the symptoms.
Wonderful, thank you. What are some of the best things someone with Parkinson's can or should do to get to sleep and then to stay asleep?
So the first thing is good sleep hygiene, having a consistent schedule, a consistent regimen that Mr. Span mentioned earlier. And that relates across the board. So you want good medication regimen. You want to try to be consistent with the timing. You want a good sleep hygiene, so as best as possible, a bedtime that's reflected every single day, and then a ritual or a hygiene schedule leading up to that that's quite consistent, meaning turning off the television 30 minutes before, and meditation can definitely help, but trying to wind down, trying to reduce stresses can all be very, very helpful. And then with regards to specific medications, there's a broad category of sleep aids that we can use, but you really want to be careful because all of them bring some form of side effect. And in general, they all have some kind of additive side effect with the primary Parkinson's medicines. As I mentioned before, the Sinemet and the dopamine agonists carry with them a risk of sedation. And if you add on top of that over-the-counter sleep aid, you may fall asleep better, but that effect can carry over to the next day. So some grogginess, almost like a hangover effect, and that can compromise balance and thinking the next morning. So we have to be very cautious of that. To be very specific, the medications or the options I like to go to first are melatonin, because it's quite safe They've been shown in clinical studies to be very effective. It does require some patience, so starting very low at 1 milligram or even 3 milligrams at night and building up. And usually when patients get to around 9 or 10 milligrams, if they're not completely controlled, I will either add on or switch the medication options. And at that point, sleep aids like Clonopin, which are definitely prescription only, or Remeron, which is an antidepressant that has a good effect, can be helpful to add on. And the last thing is to make sure that you limit caffeine and you limit certain stimulants or a high carbohydrate intake after dinner. Or it really is a very personal mechanism in terms of diet and exercise as to when that timing should be. Some patients just do much, much better if they have their exercise routine before bed, whereas others, it keeps them almost wide. It keeps them wide awake and really vigilant to see when to switch the exercise in the morning. And much like the Parkinson's medicines that we focused on today, many people are on medications for other different reasons, depression being a good one, chronic pain being the other. And some antidepressants are known to help sleep. They help you fall asleep, help you get good quality of sleep. And if you take them in the morning, for instance, they'll have the opposite effect. It will cause sedation. Well, other antidepressants, and I'll give you some examples. So Effexor or venlafaxine and Lexapro, for example, they are stimulating. And so if you take them late at night or in the afternoon, it can actually disrupt the ability to fall asleep and disrupt the quality of sleep, so you don't have good consolidated sleep. And an easy measure sometimes is move those medications to the morning. It has a rebound effect after 3 to 4 weeks of actually getting you better sleep at night as well.
Awesome. You touched on the effects of sleep aids. Do prescription sleep aids increase a person with Parkinson's risk of nighttime falls?
They definitely can. One of the reasons patients wake frequently during the night is because of insomnia, because they switch back on, the brain turns on again, the sleep structure is disrupted. But there are many other reasons, and nocturia, the need to use the bathroom at night quite frequently is something we can't avoid often. And in those situations, if you have a lot of medication on board, which can be sedating, you really have to watch out about balance problems, particularly in poor lighting, particularly at night when balance is compromised even more. And if you have compromised balance, compromised vision, and some cognitive sedation effect, it's something we have to be really wary of. And so that is why this is really a personalized decision. In patients who are having bladder problems, who have to wake frequently during the night, we try to avoid sleep aids, or we try to time them differently, maybe split the dose, one at bedtime at 9 or 10 p.m. and one in the middle of the night if needed. And we try to avoid the benzodiazepines, or Clonopin, for example, and try to steer towards the antidepressants or even melatonin. So those are some of the cautions which we have. The other is patients who are prone to dropping their blood pressure. So you could potentially add on another problem to people who are already compromised from a mobility standpoint.
That's really great information. Thank you, Dr. Lazarus. Please remember to submit any questions you have for our panelists via the Q&A icon at the bottom of your viewing page. We will get to some of our audience questions after this final discussion. Lloyd, how has sleep been affected by your Parkinson's, and what do you do to ensure a restful night?
Thanks, Amanda. Fortunately, I learned really early on, I guess I read this somewhere, is that having 8 hours of sleep a night is really good for you, and very, very healthy for you. And that actually, in particular for the brain, because the brain can only perform certain functions like removing toxins during certain phases of your sleep. And so it's important to do that. So I really focused on that. I'll admit, fortunately for me, I've not really had a problem with it. I do get up 2 or 3 times a night to go to the bathroom, but right now anyway, I'm able to get back to sleep fairly easily. One of the things that I did have early on and still have, but fortunately it's only occasionally, is I do act out in sleeping on occasion, acting out in dreams. So I try to keep an eye on that. Fortunately, my wife, we have a king size bed. She sleeps on the far edge. She likes sleeping over there, which is good. And I try to stay on the other side so that when I do have the occasion, fortunately, it's not serious. It only happens literally 1 or 2, 3 times a month. So I've kind of not done anything really about it at this point. If it gets more serious, I'll obviously seek some additional help on that. One of the things that was interesting, I think, is a great example of sleep problems is that there's so many different things that can be done with that. I read recently that, trying to focus on your circadian rhythms, your internal clock. One way to do that is when you get up in the morning, is the first thing you should do is to go and get some outdoor light. So that your body is exposed to outdoor light. So it begins to get your body on a rhythm that, okay, this waking up with light is the right time. And it's now, my body is now do that. Plus, I think which I've tried to do with all the things that I've had in the way of symptoms is to make a list of all my symptoms and look at their impact on my quality of life and begin tackling them one at a time, and then doing like Dr. Lazarus suggested and others have suggested is to get with a neurologist, a nutritionist, a physical therapist, kind of whoever it makes sense to talk to about this, and explore what all that you can do about a given symptom, and not just take the simple answer, but kind of look at everything and say, okay, let's see what works for me and gives me the best help with maybe the least amount of impact. I mean, in summary, what I've tried to focus on, my approach to things has been, I call it becoming a student of the disease. So I've tried to learn as much as I can along the way about things that are affecting me and research and other things, and then trying to employ that, whenever I could make sense for me to do that.
Wonderful. Thank you for sharing, Lloyd. Mom, you touched on this in your video, but as a care partner, how do you encourage your spouse to stay socially connected? Do you schedule dinner dates, outings? Talk to us about that. You're on mute.
There we go. How's that? Is that better? Great. We really do enjoy going out to eat. Sometimes it is for dinner, but on a Saturday or Sunday when I'm not working, we will switch and instead go out to eat for lunch instead when it's much less crowded. And we will always try to keep in mind what Wade's on and off periods are when we do know that we're going to be going out to eat. I mentioned in the video that I found a place in that instance where they took reservations. And certainly I think, one thing COVID gave us is a lot more restaurants, I feel, are accepting reservations. I think it started because they recognized they had to minimize how many patrons they would have. But I don't just depend on the app when I make a reservation. I'll go ahead and I'll call the restaurant and I'll ask them specifically for a table near the door. And whatever the motor symptom is that you might be challenged with Parkinson's, with Wade, it's absolutely about freezing. But if you can get a seat by the door, that certainly helps to eliminate some of the stress upon entry as well as exit.
That's a good tip. How do social activities help your spouse stay positive and stay energized?
I mentioned earlier that as a care partner with Wade, together we're in this Parkinson's journey, right? And I try to stay aware, and I can't overemphasize that, I don't think, to the other care partners. One of the things that I noticed, and it probably started more so about a couple of years ago, but he can much more, if he was right here sitting next to me, he'd share with you the same thing, right? That he can much more easily interact in a social conversation if it's in smaller groups. And sometimes it's the inability to quickly recall a word or a phrase that he wants to share at the right time in a conversation. Or sometimes it could be dyskinesia that could, impact the muscles that are needed for speech. In either case, it's really important just stay in a constant conversation with your Parkinson's patient. Talk to them about, how much they enjoy getting together and maintaining a socially active lifestyle. And when it is appropriate, when it feels right, do it in those smaller get-togethers where they are not just an audience to a conversation, but where they can, in a smaller group, truly become a participant in the conversation that is being discussed.
What has your doctor told you about alcohol and other considerations during social outings and activities?
It's interesting. So whenever Wade and I would go to the doctor, there's always that question right on the form. It's, do you drink? How would you describe whatever it is you're drinking? And we would always check that box. We're social drinkers. So we might have 1 or 2 glasses of wine or 1 or 2 cocktails. And, we have noticed, and the doctors have shared with us, that it can minimize the impact that Cinemet is having on him. But Wade still enjoys having a glass of wine. He still enjoys having a cocktail every once in a while. So when we're out and about, he'll get one glass of wine, he'll get one cocktail. And if he's really thirsty that night, we'll wait till we get home to maybe have that second drink. I think we have to be, aware of what the disease, puts upon us and the way we have to change some of our social interactions. But it doesn't mean you have to give everything up. At least that's been our case. And I recognize certainly that everyone's case is different. The other thing we've noticed is because the doctors have shared with us, again, that the alcohol can sometimes minimize the impact of Cinemet. Sometimes he'll take an extra half a tablet, and that can help as well.
Thank you. Brittany, are there things that a person with Parkinson's should do before bed to help with relaxation and with sleep?
Thanks, Amanda. I think Dr. Lazarus actually touched on a lot of those tips that I typically offer regarding relaxation and sleep. Definitely mindfulness and meditation, even like a deep belly breathing technique can help be calming for the body and the mind. There are different apps out there that can guide you through that too. Some that I like to recommend are Calm, Headspace, and there's one called Breath Ball too. Getting in a good routine for bedtime, like limiting screen time and turning off the TV and cell phones earlier on in the night. Limiting caffeine later in the day, getting on a regular sleep schedule. I know someone asked about napping earlier, and of course naps are good, but if you're someone that's napping all day and then not sleeping at night and getting off that normal sleep schedule, that can be detrimental. And just finding something calming to do that you enjoy before bed, whether it's listening to relaxing music, or I personally turn my phone off at like 8 or 8:30 and read a book to calm my mind and my body. Making sure that you're moving enough during the day. So exercise can help make you feel more awake during the day and help with sleep at night. But ultimately, I would definitely discuss any sleep concerns with your doctor so that they can make any recommendations to your routine or your medication schedule or whatnot to help you out there.
Awesome. Those are great tips. Thank you so much. What if pain and cramping is an issue? What are some things that you would recommend to ease these symptoms?
Good question. A lot of people with Parkinson's experience cramping and pain due to the stiffness and rigidity and some other medication side effects maybe. So getting on a good stretching program and stretching the affected muscles can help. Some people find that a light massage can help relieve some of that cramping. Thinking about how you're positioning yourself. So not positioning yourself in an overly slumped position when you're sitting in a recliner or even laying down in bed. A lot of us use way too many pillows that contribute to kind of poor positioning. Dehydration or even a nutritional deficiency can increase cramping and pain. So that would be something to check in with your primary care physician about. Again, mindfulness and relaxing activities can help calm your nervous system and calm your body, and that may have a helpful impact on the pain and the cramping. I found that a lot of people with Parkinson's complain of cramping and curling of their toes and their feet that's really uncomfortable. And sometimes I recommend to my patients to use toe socks or toe spreaders, or there's even some kinesio taping techniques I use with patients to help decrease toe curling that can help. But as always, refer back to the doctor, review your medications with them. The cramping and pain could be a side effect of a medication, or it could just be from the disease itself, and maybe your doctor needs to tweak your medication cocktail and schedule. So.
Awesome. That's really, really helpful. Thank you so much. Well, thank you so much to all of our panelists for their fantastic insights. We are now going to take some questions from our live web audience. We won't be able to address all of the questions that came in today, so please be sure to call our toll-free helpline at 1-800-4PD-INFO for answers to your Parkinson's questions. Our first question is for Dr. Lazarus. How often does increasing levodopa lead to increased cognitive difficulties like confusion and agitation in late-stage Parkinson's?
So those symptoms, those cognitive and behavioral symptoms are known to be associated with cinnamate levodopa dosing, but it's so variable. And the reason for that is that a percentage of people will develop what we call PD dementia, Parkinson's disease dementia. So cognitive problems, memory and thinking issues that affect their function in one way or the other, such that they become in need of assistance. Not everybody does. So the term advanced Parkinson's can mean so many different things. For example, patients who have walking problems and maybe some bladder control problems, maybe they use a cane, a lot of them will have intact cognition. And so increasing the cinnamate, the levodopa, can have a very positive effect on their balance and their stability and not impact their cognition at all. Whereas others do develop some cognitive problems early on and may be more sensitive to all medications, including the cinnamate. In general, and this is a very general way of describing this, patients who from a very early stage in the first 2 or 3 years have a lot of the freezing, have a poor response to cinnamate, so the cinnamate may improve the symptoms but not completely take away the symptoms, have very early bladder or bowel symptoms, have very early hallucinations or delusions. They tend to progress a little bit faster from a cognitive standpoint, and they may fall into that unfortunate category. Whereas others who, for example, present with tremor early on for a few years, have a good response to cinnamate for a few years, have minimal if any cognitive changes early on and a good balance control, they may fall in the category where you can really push the threshold of cinnamate even after 8 or 9 or 10 years. And from a cognitive standpoint, they tolerate it well, but then you worry about the dyskinesia, the movement problem, or the cognitive problem. And secondly, certain patients later on develop sedation, become really sleepy on the cinnamate, even if they've been tolerating it for a while, for many years. And that can kind of present itself like cognitive complaints, so difficulty of concentration and attention. It may just need adjusting the timing of the dose so they're not as sedated, or splitting up the doses, but you can still keep the total daily dose.
Wonderful. Thank you for those answers. It's very helpful. Our second question is for Lloyd. Do you ever experience fatigue during the day? And if so, what are some ways that you combat that?
Well, I do actually. It seems to always happen in the afternoon. I'm usually good all morning long, but for some reason, middle of the afternoon, particularly if I've been active doing some things. And like I think I commented earlier, is that what I try to do is, if I know I'm going to be doing something regularly for the week, I'll middle of the afternoon, I'll take an additional half tablet of cinnamate just to help out and kind of get me through. And then if I am really weak, I really just come in, take a shower, and sit in a chair and truly relax my body and allow myself to relax. And that seems to rejuvenate me. And usually within an hour or two, I'm feeling much better, at least better than I was when I started. But that's what I focus on.
That's very helpful. Thank you so much. This third question is for Brittany. Would you suggest that anyone diagnosed with Parkinson's visit a physical therapist immediately upon diagnosis, even if they aren't experiencing any movement challenges?
Yeah, that's actually one of my favorite questions. It's a common misunderstanding that you don't really need to go to a physical therapist until later on in the disease when your symptoms are more severe or you're falling. And really, we are able to do the most for you as physical therapists when you come see us early on in your diagnosis. So we work with the physicians closely to try to get people to therapy as soon as they're diagnosed. And even if they're doing very well and have very mild impairments, we can get some baseline testing for your mobility and your balance and your walking and strength. And that can help us identify any mild impairments you're having and then give you appropriate exercises to keep those impairments mild for as long as possible. It also serves as a baseline. We typically have our patients come check in once every 6 months and go through a round of therapy once every year. So once we get that baseline testing, we can check back in every 6 months and see if you're experiencing any changes and stay on top of that before anything bad happens. So, and as we mentioned earlier, we can help you get started on a good exercise routine from off the bat.
Wonderful, thank you. Question 4, Mom, what have you found is the most helpful thing you can do to keep Dad exercising and motivated to stay moving?
Oh gosh, so let me think. I think we just have to we keep talking about you have to keep leaning in, right? The disease is not going away. We don't have to embrace it. We don't have to fight against it, but we have to keep leaning in and making adjustments as needed. And, you know, I'll tease him, right? I mean, if it's time to get up and move, if he's having, you know, a lot of rigidity or freezing, it's time to stretch. And, you know, not now, maybe in an hour, you know, okay, after this, after that, you know, we'll say, hey, in the absence of yes, you're telling me no, and we're not taking no, right? So I think maybe the answer kind of goes back to what was in the question, but it's being a motivator. And also, if you have the luxury of doing it with your care partner or with your person that has disease and you're the care partner, then do it with them. Like we've all talked, right? Probably none of us exercise enough. I think I exercise now more than I certainly ever did until we started on this Parkinson's journey. So make it something that you do together, and then it becomes a little bit more fun.
Awesome. Thank you for that. Dr. Lazarus, how many stages of Parkinson's are there, and how is each stage determined? What is the long-term prognosis of someone diagnosed?
So the first thing I want to comment on is that in 2021, Parkinson's is, unfortunately, it's an incurable disease, but it doesn't affect life expectancy. So in general, patients don't die from Parkinson's. Unfortunately, they die with it, and we need to ameliorate those symptoms to make sure quality of life is really maintained. The staging we use from a clinical standpoint, so when we see someone and examine them in the office, is something called a Hoehn-Yahr staging. So there's 4 stages. And if you have stage 1, it's just one side of the body. Stage 2 will be symptoms on both sides. If you have a little bit of that involved problem stage, it'll be stage 3. But I try not to hinge too much on that because patients can fluctuate quite dramatically. They can even fluctuate during the course of a day based on the response to levodopa. So someone can be at stage 2 early morning, and an hour and a half later, when the levodopa has kicked in, tremor and symptoms on one side of the body are completely invisible. They're really well controlled until they're stage 1. What's more important is to track kind of your function and quality of life. Quality of life is the single biggest goal of treating Parkinson's as a whole. So if you feel that 3 months ago you had more difficulty in mobility, for example, in cognitive tasks and just general tasks related to daily living, and you're in a better place now, then you're probably on the right trajectory, the right track in terms of the lifestyle that we mentioned and the medications we mentioned. Conversely, we worry if we see patients at the 6-month visit and things are not going so well at work, and there's some concerns at work, for example, from a cognitive standpoint, or they're having challenges driving, or they need more help with ADLs like dressing, for example, have had to adjust to adapt the way they're eating because of tremor. And those are a sign to us that those changes in their function need to be addressed because they're overall at a different place now.
Wonderful, thank you. Lloyd, as a student of the disease, who do you talk to about your research findings, and what are some of the resources that you found that have been the most helpful throughout your journey?
Well, that's an interesting question. You know, there's a website in particular that actually keeps me posted of research. And so I find it interesting to read research. I find it kind of a double-edged sword. Is one, it's always interesting to see what's kind of been looking into, and usually very promising. The downside is it always seems to be 3 or 4 years out before they're going to come to fruition and have something available for use. But so I'm encouraged by that, and that actually, if I get down about it, I often think about things that I've read, like some of the stem cell research is going on right now is really, really promising, and I think it's going to be one of the breakthroughs for it. But it's still a few years out in the way of being something that's going to be readily available. The other that I found is a naturopathic doctor out of Seattle, Washington, is Dr. Laurie Mishley. She is with Seattle Integrative Medicine, and she both is a researcher as well as a practitioner and all she does is work with people with Parkinson's. I found working with her, she deals with the exercise aspect, the nutrition aspect. Although she's out in Seattle, I'm able to do remote telemedicine with her. And she's probably been one of the greatest influences that I've had on my overall, in addition to my neurologist, which I have 2 who help me with that. And then physical therapy probably is my 3rd. So I try to use all of those resources to kind of focus on what makes sense for me, where I am right now in my particular stage of the disease.
That's wonderful. Thank you so much for that information. Dr. Lazarus, this person asks, my husband uses Inbrija for his downtime sometimes between levodopa dosages. It seems to help a lot. Do you have any thoughts on whether there is any downside to that?
It's a good question. Inbrija is, just to recap, it's another form of levodopa. So the cinnamate is replacing the levodopa that's lost in the brain. It's absorbed through the gut, and it requires certain gut integrity, so good gut function. Patients, for example, who have trouble with a lot of constipation or what we call autonomic dysfunction, unfortunately have an effect where the medication is not absorbed very well, regardless of the protein intake, the dietary intake, the general health. It's beyond our control sometimes. And so medications fluctuate. The 8 a.m. dose may work perfectly. The 11 a.m. dose may not kick in at all because the tablet is stuck high up the gut where it's absorbed. And then you have 2 or 3 doses that kick in all at once at 3 or 4 p.m. and you have the dyskinesia. And so the effect is up and down, really fluctuates as a variable. And that's the daily experience of patients with Parkinson's. So a way of kind of getting around the GI side effects is to administer medications that don't go through the gut. And a good example is Inbrija. Inbrija, the same active molecule as levodopa, but it's inhaled. And because it's inhaled, it's absorbed through the lungs. And as a result, it can be more predictable in how much gets in and the clinical response. So you will know the response to Inbrija is pretty stereotypical. It's pretty much the same for a given patient each time they use it. The downsides then are essentially it's an added dose of levodopa. So any side effect that the patient experiences or can experience with levodopa could be experienced with Inbrija. An example of that would be dyskinesia, if they had dyskinesia with their regular dose. Patients who are hallucinating at baseline and have a lot of paranoia, a lot of cognitive problems and are very sensitive to it, would either adjust the dose or be wary of it because it can worsen the hallucinations for that period of time. Sedation is another one. And unique to Inbrija is that patients with severe glaucoma need to be cleared by the ophthalmologist because it can increase that pressure. And of course, because it's absorbed through the lungs, patients who have asthma, who have developed lung problems, such as COPD, may need to be concerned. We will now probably throw COVID into that category, although we're not really sure the long-term lung effects of COVID in general or in Parkinson's patients. So that's something to be very wary of. But there's no unique side effects that you need to really be concerned about.
Wonderful. Thank you so much for answering that.
Oh.
Well, I want to thank our incredible panelists and video stars for their time today. I also want to thank all of you for being here and showing your support. We hope that you got a lot out of our conversations. I want to thank again today's program sponsor, Amneal, for their unwavering support. We invite you to learn more about this sponsor by visiting our chapter supporters page. We look forward to seeing all of you back in person this fall at an educational program and at Moving Day Atlanta. For more information on upcoming events, please visit parkinson.org/events or call our helpline at 1-800-4PD-INFO. Have a great weekend, everyone.